fellowship in sports medicine and in pediatric sports medicine. And we're happy to have him join SMASA as one of our new surgeons. Jeremy Rush.
Thank you. Thanks, guys. Well, thank you guys for having me. I wanted to start off, this is my contact information. So I put my email and my cell phone number up here. Is it a little too loud? No. You got outvoted. They said no. Are you sure? Okay. All right. Fair enough. So this has my cell phone number on it. You guys, please take my cell phone. I give my cell phone to every trainer, PT, referring physician. You guys don't ever hesitate to send me a text if you ever have a patient you have questions on, you want to have someone take a look at x-rays, you need to bounce off an idea, but that's why I give it to everybody. As Dr. Schmidt mentioned, I am an orthopedic surgeon. I'm dual fellowship trained in pediatric orthopedics as well as orthopedic sports medicine. So my real focus is taking care of young athletes, all the way from our 3-year-old soccer and t-ball players all the way up to our collegiate and professional athletes. Thank you guys for having me today. Our talk is going to focus on syndesmosis injuries or high ankle sprains. And I want to say right off the bat that I learn more from you guys than you're probably going to learn from me. Every time I work with Todd or Jesse or one of the other fine athletic trainers in here, I pick up new tricks and tips on evaluation and management. So by no means am I going to give you guys a lot of information on what you do when it comes to being an athletic trainer and treating syndesmosis injuries. The real goal that I have is to delve a little bit more into the mechanism of injury and then talk a little bit about when Dr. Schmidt, myself, and Dr. Glebus think about operating on these injuries. So hopefully it's a little bit of overview of the mechanism and a little intro to surgical treatment and when we pull the trigger on surgery. These are my disclosures. I have no disclosures relevant to this particular talk. Later on, I do mention a proprietary device called the tightrope. And that's something you guys have probably all heard of. It's made by Arthrex. You know, it's out there, so I don't mind saying that name. But unfortunately, I have no financial connection to that, and I get no royalties, and I have no connection whatsoever. So moving on. So syndesmosis injuries, especially this time of year, it seems like this is where there's always a really, really big focus. As football, especially the NFL, is getting to playoff time and crunch time, it seems like these injuries really start showing up and really becoming kind of national focus, if you will. And a couple years back, you guys all know that there was a lot of media attention to tightrope, syndesmosis fixation, when Tua at Alabama had, kind of back-to-back syndesmosis injuries, underwent surgical treatment by the guys at ASMI, and then I think he was able to come back and play, 2 or 3 weeks later. And that really prompted a lot of discussions in my office, probably in your training room, but a lot of athletes and parents asking about syndesmosis injuries, when we treat them surgically, and what the deal is. So these are our objectives for today. As I mentioned, we're going to touch on anatomy, mechanism of injury, and then talk a little bit about when, as a surgeon, I would consider surgical treatment for these. So sprained ankles, ankle injuries are ubiquitous in what we do, incredibly common. It's probably the most common injury that we see on a day-to-day basis, and we know that it can result in a significant loss of playing time. Obviously, basketball, volleyball, soccer, football, that's where we see a lot of it. And we know that when you look at especially basketball and volleyball, ankle injuries in general represent about 1/4 of total injuries. To kind of start off with a little bit of anatomy, you guys have probably heard the word mortise. Mortise is a term that we use all the time when it comes to the ankle and ankle radiographs. But the mortise is a woodworking term that actually dates back several thousand years. I'm not a carpenter, but I thought this was kind of cool. The mortise and tenon, and if I'm pronouncing that, somebody correct me, but the mortise and tenon was a woodworking strategy, if you will, for joining two pieces of wood at a right angle. And you can see it's kind of this, almost like a T and a U where it fits in. It's very stable, and it's a great carpentry technique. And in the ankle, we have the ankle mortise, and you can see that the distal tibia and the fibula form that cup, if you will, that the talus resides in, and we call that the mortise joint. We know that the ankle ligaments, and I won't go over this, I won't take too long on this, but we know that we have the collateral ligaments, and then we have the syndesmotic ligaments. So the collateral ligaments are your ATFL, your CFL, your PTFL, and then your deltoid over on the medial side. So we're not going to talk a whole lot about collateral ligament injuries, that typical lateral ankle sprain. We're really going to focus on the syndesmotic injuries. So what exactly are the syndesmotic ligaments? Depending upon what paper you read, what textbook you read, there's some different descriptions of these, but in general, you have the AITFL, the anterior inferior tibiofibular ligament. Orthopedic surgeons are not very smart, so we tend to name ligaments just on anatomy where they go. So AITFL, and then you have the PITFL in the back, the interosseous ligament that runs the length of between the tibia and the fibula. So those are kind of the three major components, if you will. The AITFL is very important because that's usually the first ligament injured in a syndesmotic injury. But when you look biomechanically, it's actually probably the weakest of the ligaments. During that external rotation stress, like I mentioned, it's the one that sees the initial stress, and it's the one that's injured initially. And in the PITFL at the very back is biomechanically the strongest component of the syndesmosis, and it provides about 35% of the overall stability. Now, because it is at the back, during that typical external rotation stress, that's the one that's usually injured last. So usually you have tearing of the AITFL, followed by the interosseous ligament, and ultimately the PITFL at the very end, if you will. And we'll talk here in a second about why that's important. We know in the lab that if you go in and you section or you cut each of these ligaments, with each additional ligament that you cut, you get more diastasis or instability between the tibia and the fibula. All the way up to when you section the PITFL, you have almost a centimeter of diastasis. So why do we care about any of this? Why do we care about the syndesmosis? The syndesmotic ligaments maintain that joint, the distal tibiofibular joint. What it's primarily doing is resisting external rotation stress, it's resisting lateral translation, and it's resisting proximal migration of the fibula, kind of doing those three things in component. And again, when you think of the mechanism, that kind of makes sense with the mechanism of injury, which we'll talk about here in a minute. We also know that when you have displacement of the talus, when you have lateral displacement of the talus, you're increasing the pressure at that cartilage of the talus and the distal tibia. So a little bit of physics, which is always fun. We know that pressure equals force divided by area. So for a given patient, the force is unchanged, right? Whether they have a syndesmosis ligament injury or not, they weigh the same amount, they're doing the same thing. So in a normal ankle, you're distributing that force over the entire area of the distal tibia and the talus, right? But when you have a syndesmosis injury, you get lateral translation of the talus. And even with a little bit of lateral translation, what that does is it decreases the area. You're still putting the same pressure across it, force across it, and you end up with more pressure. And the reason why that's important is that leads to cartilage injury. It leads to ankle instability, leads to early arthritis. We call this talar escape, like the talus is trying to run away. But when you have talar escape, that's obviously bad. You can't, it's difficult to participate in cutting sports, but long term, it leads to arthritis, cartilage injury, and all sorts of problems. So lateral ligamentous injury, lateral ankle injury, just to kind of review, this is a inversion injury, right? Inversion and internal rotation. So when you look at the ankle kind of in cartoon fashion, when you have that typical collateral ligament injury, you have inversion of the hindfoot and internal rotation. And as you have increasing amounts of stress, that leads to tearing of the ATFL, tearing of the CFL, and then the other thing that really goes hand in hand is chondral injury. So we know that osteochondral lesions of the talus, there's a high incidence of those with collateral ligament injuries. especially patients who have chronic ankle instability and they keep having ankle sprains, all right? So that's kind of the mechanism for lateral ankle sprain, collateral ligament injury. So when we think about syndesmosis injuries, it's kind of the opposite. It is the opposite. It's external rotation eversion, okay? The other component is that usually the ankle is in dorsiflexion, all right? That's not universal, but often your ankle will be in dorsiflexion during this injury. When you look at the talus, this is the talus, the anterior aspect of the talus is wider than the posterior aspect. The reason why that's important is when you dorsiflex your ankle, the wider component of the talus is engaging that mortise, and that's when you have, stressing, if you will, of the tibia and fibula, when you have that dorsiflexion, because the wider talus is kind of pushing apart the tibia and the fibula. So for our syndesmotic injuries, the mechanism is external rotation, dorsiflexion, and eversion. One of the first components is deltoid injury, and the energy then follows, and you have injury to the syndesmotic components, the AITFL, then the interosseous, then the PITFL. And then with progressive injury, that energy can travel up the interosseous membrane, interosseous ligament between the tibia and fibula, and that's where you get the proximal fibula fracture. And that's another kind of teaching point, or another key point that I really wanted to bring out, is that when you guys have a patient with a high ankle injury, always think about the proximal fibula as well. You always want to palpate the proximal fibula, squeeze test, and make sure that they don't have a concomitant proximal fibula fracture. We call that a Mason-Neuve fracture. So aside from football, which is obviously probably the classic syndesmotic injury sport, we also see syndesmotic injuries in other combat and contact sports. So hockey, rugby. You see a lot of these in bull riding because of that external rotation stress when you're bucked off the bull. We see it in alpine skiing and in lacrosse as well. So on physical exam, I like to think about the distal fibula as a clock. And as you're palpating, and palpation gives you a ton of information. If you're at the 3 o'clock, 3 o'clock is the ATFL, or your collateral ligament. 6 o'clock is CFL. 9 o'clock is your PTFL. And then once you start getting up to that noon position and more proximal, that's when you start thinking about syndesmotic injury and high ankle sprain. So palpation, obviously after observation, is probably one of the more important physical exam findings. They actually did, this paper is about 20 years old, but it's kind of a neat paper. I just said neat, but anyway, it's kind of an interesting paper. And what they found was that the amount of tenderness and the length of tenderness that a patient had on exam was related to how many days they were going to miss from sports. And you can see this graph it's not a perfect linear fit, but they found that the more proximal the tenderness extended, the longer they were going to be out from sports. And they actually came up with this little formula that you could try applying. And it kind of makes sense. If the patient is tender more proximally, that means that energy has traveled more proximally. It was a more significant mechanism. It's going to take longer to recover from. The other things on physical examination, reduced dorsiflexion, and that's primarily pain. So we know that the talus is wider anteriorly. So when you dorsiflex, you load the syndesmosis. If you have an injury, then it's going to be painful. The squeeze test, the proximal tib-fib squeeze test, is one that we hear about. And then the one that you probably see the most in textbooks is external rotation. So doing that external rotation stress test, especially with the ankle and dorsiflexion, if they have pain along the syndesmosis, that's a positive test. That's a positive external rotation stress. The other test that I think is interesting is this one, the crossed leg test, where you have the affected ankle across the contralateral knee, and then you apply a downward pressure on the tibia. And it's kind of reproducing your tib-fib squeeze test, but this is one that we hear about all the time. And then finally, stabilization test. And this is one that I think Todd might have showed me. So this is where I learned more from you guys than you probably learned from me. This is in my mind, this makes a ton of sense. You have a patient with a syndesmosis injury. They are unable to run because of pain, and you're trying to figure out what's going on. So you tape them, you recreate that support that's offered by the syndesmosis, and then you have them repeat those functional activities. And if you find that their pain is improved or resolved, well, that's telling you that what you're replacing is what's actually injured. So I like this. I really like this test because it seems simple and it makes a lot of sense to me. Doing a stabilization test, repeating your functional movements, and see how they do. When we see these patients in clinic, whether it's one of my non-operative partners, a surgeon, an ER, or primary care, the initial radiographic study of choice is an ankle radiograph, so an AP, lateral, and then that mortise view, which is a perfect view of the talus. And then I will often get tibia films as well. So again, going back to that Mason-Neuve fracture, you want to make sure that they don't have a proximal fibula fracture, because the energy, just like you hear like a lightning bolt, travels, the energy travels the same way. And that energy will travel through the deltoid, across the tibiotalar joint, through the syndesmotic ligaments, and then it can exit proximally, and a patient can sustain a proximal fibula fracture. So I have a very low threshold to get a tibia radiograph. So that's my other, key point for you guys. Think about the proximal fibula when you have a high ankle injury. On radiographs, the things that you'll see with a syndesmotic injury are increased medial clear space, again, denoting that talus has translated laterally. You'll see increased clear space between the tibia and fibula, same story. There's increased distance between those two bones, and then decreased tib-fib overlap. And there's a lot of, numerical measurements. Obviously, don't have to memorize that, but a lot of numerical measurements that we look at. Now, obviously, an x-ray like this, there's clearly something horribly wrong, and you don't need to get out your ruler and your calipers to do that. But I think I put this on here just because it illustrates it. It illustrates those measurements. Other imaging modalities, CT scan, MRI, and arthroscopy. So MRI is one that I think is most helpful because it's showing you the ligamentous structures, obviously. The CT scan can show you the bony anatomy and if the fibula is malreduced, but MRI is really the most helpful, at least in my hands. And then you can examine the syndesmosis arthroscopically as well. So classification. So orthopedic surgeons love classification systems. Like, that's what you learn in residency is literally the hundreds of classification systems. And syndesmosis injuries are no different. The problem is there's really not a good classification system for high ankle injuries, for syndesmotic injuries. You can definitely look at timing. You can look at chronicity, acute injuries, and chronic or subacute injuries. But when you start getting into like the grade 1, grade 2, grade 3, partial tear, complete tear, latent unstable, frankly unstable, it gets confusing. And I'm the first to admit that. It gets really confusing. So the way I like to think about acute injuries, so the injury that happened a week or two ago, the way I like to think about it is utilizing, this is a European classification system, which seems a little busy up here, but we'll kind of walk through the acute side, and I think it's the most helpful. So first off, you have stable injuries. So a stable syndesmotic injury, you have partial injury to the ligaments. Usually the deltoid is intact, and you don't have any of that diastasis. All those radiographic measurements, none of those are positive. The fibula is where it needs to be, the talus has not escaped laterally, and it's a stable injury, can be treated conservatively or non-operatively. That's a stable injury. And then we have the unstable injury. And when we think about unstable, we classify them, or at least I like this, we classify it as latent, meaning I need to do something to it to show that it's unstable, or frank instability, meaning it's clear-cut, it's obvious. So in a latent unstable syndesmotic injury, you have injury, but with just plain non-weight-bearing x-rays, it may look fine, right? You got to do something. You got to do stress x-rays, arthroscopy, have to do something to figure out if it's unstable. And then frank instability, it's clear cut. So this is not a dilemma. This is not a diagnostic dilemma, right? You see the talus is off to the side. This is a frankly unstable injury. We know what to do with this. The problem is this patient. It looks okay on x-ray. So does this patient have a stable injury that's going to do well? Or do they have one that's latent unstable where if we stress it, it's going to show that instability? And I think for me, the next step in that scenario is to get an MRI. I think the MRI is helpful in that scenario. And on the MRI, I look at that PITFL, that ligament at the back, because we know that once the PITFL is injured, the injury has gone through the AITFL, the interosseous ligament. That's kind of the last defense, if you will. So on the MRI, if the PITFL is injured, that goes along with our instability, okay? You can also get stress x-rays in the OR or in your clinic if you want to, do that. But MRI is also very helpful. So treatment of stable injuries, and again, this is where you guys are more of an expert on this than I am, so I'm not going to belabor this part. But as a general rule, the goal of the acute phase is to protect the joint, minimize pain, minimize swelling, and preserve range of motion, reduce inflammation. I will usually put these in a walking or a cam boot if it is a stable injury. You avoid that kind of forced dorsiflexion and external rotation because that's what loads the joint. And then, usually put them on crutches, protected weight bearing. Compression, ice, game ready, anti-inflammatories, gentle range of motion, kind of all those modalities that you guys are so good at. And then as their pain and inflammation improve, we progress back to full weight bearing, usually with a lace-up ankle brace. The subacute phase, our goals are to normalize mobility, improve strength, and then start restoring that neuromuscular control. And then finally moving on to the advanced phase where we start introducing sport-specific movements, more plyometrics, and then kind of advancing with the goal of returning to sport. So this is the other kind of key thing that I wanted to convey, and I think, this is out there, but return to play. When you counsel your athletes, we know that return to play after a syndesmosis injury is much longer than a typical lateral ankle sprain or collateral ligament sprain. So, a couple papers up here. These are a couple years old, but Wright's paper looking at NHL players found a mean return to play of about 45 days. Daryl Ospar, who's out in Florida, looked at 36 NFL players. He found their return to play was about 15 days versus about a week for a collateral ligament injury. And then Alfred Mansour, who's over in Houston, looked, I think he did this during his fellowship, he looked at NFL players as well. He found a return to play of around 15 days with a corticosteroid injection. That was the point of their paper, was looking retrospectively at, will a steroid injection help return to play? And the answer to that, at least based upon the evidence that we have, is that steroid injection can be helpful, especially in your collegiate or professional athletes. I don't know if I would be doing that in a high school kid. I think you have to have that discussion with the family. But certainly in your higher level athletes, maybe your junior, senior that's getting college looks, you can think about a steroid injection. That most likely does improve and reduce their return to play timeline. So moving on to the fun stuff for me. So operative treatment, when we operate on these, is for the frankly unstable injuries. So that one, which is a really, really bad injury. That's not an athletic injury. That was like a fall from a roof. And then your latent unstable injuries where you have instability noted on your stress x-rays or your MRI, especially in your high-level athletes. Now, where that gets a little more controversial is in your, perhaps less than high-level athletes, maybe your middle schoolers, your freshman, sophomore. Do you treat those patients in a cast because they will likely heal, or do you think about surgery with a quicker return to play? And that's a whole can of worms on itself. But latent unstable injuries, we at least have that conversation about surgery. So The gold standard for surgical fixation for syndesmotic injuries is screw fixation. So 1 or 2 screws that go all the way across the syndesmosis. And I know you guys have seen these. The fundamental problem with this is that they usually break. In fact, when I talk to my patients, and I haven't done screws in a while, but when I would talk to patients, I would tell them the screw is going to break at some point. The reason why is the syndesmosis has motion. It's supposed to have some motion. So when you put a screw across there, a screw is just like a paper clip. And with that repetitive motion, ultimately the screw will break. So you have to be prepared to either take it out, leave it in if it's broken, but you have to have that conversation with the family. You can kind of see when it does break, you can get out the head of the screw, but obviously the part that's in the tibia is kind of like how do you get that out? That's a little bit dicier, if not impossible. So again, screw breakage, and then after we take the screws out, there is reported complications of that diastasis coming right back. So what a lot of us use now is what's called suture button fixation. Again, there's every company, Biomet, Smith & Nephew, Arthrex, every company has a version of this. So I don't mind saying the brand name, but again, I have no financial relationships to that brand name. But this is called the tightrope, if you will. But every company has one of these. And what this is a high strength, non-absorbable suture with 2 buttons, 2 metal buttons, one that goes on the medial cortex of the tibia and another one on the lateral cortex of the fibula. It's adjustable, so when you pull those tails of the suture, it shortens the length and you're able to restore stability. So that's the tightrope construct, if you will. The benefit for this is because it's suture, it allows some more motion. You have more of that normal motion at the syndesmosis that you would have normally in an uninjured patient. There's less need for removal because that little metal button is flush against the bone. And then you may have less malreduction or inappropriate reduction. Some of the drawbacks, it costs more, and then potential for overuse. Applying this to patients that probably don't need a surgery. That's a risk here. There have been several studies looking at button versus screw, and they found that the button group has higher functional scores, less broken hardware, less implant removal, less malreduction. Again, kind of keeping with all those things I mentioned a second ago. And then I had just kind of one example. This is a 17-year-old. This is probably from 2 years ago, high school kid. Kind of a typical external rotation stress injury during a football game, exam lined up with a syndesmotic injury. The interesting thing was he falls into that latent unstable injury. So on his initial x-rays, he was reduced. None of those x-ray measurements were abnormal, but an MRI showed a high-grade PITFL tear. And when I took him to the operating room and stressed him, he did have widening of that clear space. So again, this falls into that category of it looks like it's stable, but when you stress it, it's actually unstable. He was treated with suture button fixation, to use the generic name. And here you see that there's actually, you don't see the suture because it doesn't show up on x-ray, but there's 2 sutures and 2 button constructs going across the tib-fib joint. Cam boot for 4 weeks. He progressed to weight bearing as tolerated after 2 weeks, started running at 6 weeks, sport-specific drills, and then returned to sport at 3 months. Now that's me. I'm full disclosure, I'm a little bit more conservative than high school kids. I know for a fact in a professional athlete, you probably speed that up. But that was my rehab protocol with him, and he did very well. So in summary, just a couple of the things just to kind of go over. Have a high index for suspicion for these injuries. We know that they take longer to recover from, so that's good for counseling athletes and their families. Have a low threshold for referral. And then for me, I have a low threshold for either stress x-rays or an MRI. And then I know we talked about the mechanism of injury as well. Mechanism of injury is so important, not just for ankle injuries, but for all injuries. Getting that mechanism and applying that to the injury pattern. And I think that's it. This is my cell phone and my email once again. Any questions, anything I can ever help with, you guys let me know. And otherwise, I'll take questions from the floor. Yes, sir. Yeah. No, that's a great question, and that's something that I probably should have said, and I probably shouldn't have glossed over. This talk was, just ligamentous injuries, but just like you mentioned, distal fibula fractures are associated with syndesmotic injuries, right? And the higher the fibula fracture is, the higher the chance of a syndesmotic injury. So let's just take this kid's x-ray as an example. If his fibula fracture was right here, where, can you all see my mouse? No, you can't see my mouse. So if his fibula, well, I'm not that tall. I can't believe, I thought about jumping, but that's a horrible idea. There you go. Yeah. So high tech. So if your fibula fracture is up there, we know that you have a close to 100% risk or 100% chance of having a syndesmotic injury, because it's that lightning bolt, right? That lightning bolt traveled through the syndesmosis as it was going out the distal fibula. So to your point, with that injury, when you treat the fracture, you plate the fracture, you treat it with plates and screws, and then you reassess the syndesmosis, you stress it, and if it's still unstable, if all those x-ray measurements are positive at the time of surgery, then you stabilize the syndesmosis. So if you had a high fibula, I would open the fibula, reduce the fibula, put a screw in, a lag screw, and then a neutralization plate with an additional 6 or 7 screws, and then I would grab, there's a better medical term, but I would grab the fibula and I would translate it laterally. It's called a cotton test. And if the ankle is unstable, then I would put a suture button device or a tightrope in. So that's the course of events. So the long-winded answer to your question is you fix it at the time of surgery. Yep. Yeah, in that scenario, honestly, your return to play is dictated by the fracture. So your return to play is dictated by the distal fibula fracture healing. Yep. Good question. All right, guys, anything else? All right, well, thank you all, and you guys have a great day.